Good morning. Good morning, Professor Casadei from the ESC 2020 virtually.
Good morning.
Good morning. As the president of the European Society of Cardiology, how did the ESC assist cardiologists across Europe to steer through the corona crisis?
We have been working very close with the president-elect, which is Professor Stefan Hachenbach from Langen. And together we have really tried our very best to support the cardiologists, but it has been a two-way communication. We felt very much supported by the national cardiac societies, and we supported the National Cardiac Society to really try and maintain the priorities of cardiologists and patients with cardiovascular disease alive during this health crisis. So that has been, very important. So we've had several written communication. We've opened a new web page. We have created a living document in this web page that was continually updated to have, because as you know, the information came in and changed all the time. There was new evidence coming up every day. And so we made sure that we bypassed all the normal, traditional, if you like, slow channels in order to provide that. We've also provided a page for patients curated by our patients forum. And all of this had hundreds of thousands of visitors per day. So it's been really a fantastic opportunity that of working really close, both with the patients and with our national cardiac societies.
Related to those challenges, or maybe also through this collaborations that you just mentioned, would you say there were any particular learnings for cardiologists during this time?
Oh yes, a huge amount we've learned. Well, first of all, we have been reminded, and we need to be reminded of the fact that cardiovascular disease is a much bigger problem than COVID. Yeah, the numbers are very clear, and there is absolutely no reason for us to be complacent in that respect. The lesson number two has been that the reorganization of the clinical services due to COVID has actually the potential of generating a very large collateral damage. Up to in some regions that have been hit very hard by COVID, we have seen that almost 50% of the excess deaths at that period was not due by COVID. And although the data from mortality, you can be absolutely certain that everybody was classified correctly, there is a clear evidence that there has been collateral damage, people dying unnecessarily because of the reorganization or because they didn't feel like coming to hospital, fear of infection, the exhortation of stay at home, don't overburden your hospital. So all of this has actually been quite damaging to our patients, in particular to patients with common diseases like cardiovascular disease. And so that has been another lesson. A positive lesson has been how you easily, win an emergency, how you can cut the red tape without compromising quality of what you do. And this has been very clear with the clinical trials that have been initiated, both the recovery trial and the solidarity trial. They have shown that you can provide, you can design a very effective clinical trial that you do not compromise on quality, but you can do this very rapidly, very effectively by working within the health systems. And this is something that we must not forget, really. And also the strength of the profession, how much we have been able to raise to the occasion without micromanagement. And that, I think, is also a very important message, that there is a huge still vocational aspects in health professionals, and that should be valued instead of being doubted or questioned or micromanaged all the time.
Touching onto that, or coming onto that, because we were just talking before we started the interview about the positive aspects of doing a congress virtually, and you mentioned that more women and lesser successful economic countries can participate now in the congress. Could you just summarize a little bit about what you mean? Because I think it plays into the fact what you just said now, that the vocation comes stronger together, basically.
Exactly. No, we were absolutely delighted to see so many women registering to the Congress, the highest proportion ever. And also to see countries like Mexico, Argentina, Brazil really joining us in the very, very high numbers. And also tweeting, saying how wonderful it is for us, for the Mexican cardiologists, to join the European Society of Cardiology meeting. So every time these things happen, I like to make the argument that I made for the National Cardiac Society. It's always a two-way system. I think that if more cardiologists from low middle income economy or middle income economies are joining in, it would also influence the way we design the Congress, the way we think about cardiology, because at the moment we do, if you like, we focus a lot on luxury cardiology, right? Whereas most of the people out there are still doing thrombolysis, right? And so why don't we talk about thrombolysis? Why don't we talk about, how can we achieve, if not the same, a very closely similar results in a much more cost-effective way in different countries, in different realities. And, last year we did the global health was the focus, and I am very, very keen in continuing us thinking along these lines. And I think if we have a good contingent of cardiologists from countries where they are still trying to organize their health system in a more thrifty way, we will learn. And I think it will be good for both.
And that sounds fascinating, and I think this is very important also for the development of European associations in general, to have a more world perspective on the field in general. You will hold 2 presentations on atrial fibrillation. Yes. Could you just summarize what they will be about, and whether you also included a global perspective on this particular area?
Yeah, it's not so much a global perspective. I mean, everybody knows that atrial fibrillation is a global problem and is the most common arrhythmia. And I always think of atrial fibrillation a bit like one thinks of aging. It's a disease that comes, as a result, or this is a condition that happens as a result of a long-term exposure to what are environmental and genetic factors. And so, like when you deal with aging, you can try and understand what is happening and how this influence are actually affecting and bringing the disease. Or you can have plastic surgery and cover it up, and then for a while, it would look as if you're young again, but in reality, inside you're not. And this is, I think, exactly the approach that one can take with atrial fibrillation. And I'm very, very keen in trying to understand what is behind what is the process, that brings then atrial fibrillation, and therefore, how one may find new targets and new treatments that are a bit less conventional than what we're doing now. I think you have seen here from the guidelines that there is a recognition that there isn't such a thing as low atrial fibrillation, that is always in a context, is always in the context of comorbidity, of aging. And I think it's challenging, but one really needs to understand that.
The Congress is up and running, and at the moment, could you just, summarize the most interesting hotline topics that we can still be looking forward to?
We have been blessed by fantastic hotlines. And what I really like about them is their variety. Because we both have new approaches and new drugs, but also repurposing of old drugs like colchicine, like trimetazine, the idea of having a metabolic modifiers in ischemic heart disease. We have investigator-led trials, and we got pharma-led trials. And, it is really fantastic to see that kind of variety, because I'm always very much concern about the drying up of the investment of pharma and cardiovascular disease because it's too difficult. And for instance, for the glyphosines, it's very nice to see how a drug that was marketed for diabetes has now become a major hit for heart failure. And we will see with DAPA-CKD, it will be, even clearer the impact of this drug on chronic kidney disease. So I think that would definitely be extremely interesting. But we also have, trials that question, I find also very interesting, the practice that we normally do. Transfusion, non-transfusion, like as we had in the past, oxygen, non-oxygen. And this is also very important. I think that to see that the community, it keeps questioning and finds a way of doing trials, even if there isn't a strong commercial interest behind it. And you have to give credit to the investigators for doing that, because I have done an investigator-led trial, and you basically have to raise the money whilst you're doing it. Otherwise, you would never start. And it's a major challenge. And I like the idea that people still want to go for it.
Well, that sounds uplifting and great, and we'll be looking forward to watch the rest of the Congress. And we wish you, all the success with your presentations and loads of viewers. And thank you very much for this interview and for setting up this fantastic Congress virtually.